provide some opening remarks. So please welcome Elder McIntosh. A microphone is coming, but till then.
Howdy. Howdy. Bandada Hunzu, good morning. So this is an exciting collaboration between Northern Health and the research for health, UMBC Health Research Institute, which is really good because today, as always, it's about collaboration and building relationships and understanding each other and coming together. So you're working on the same page rather than two separate departments or however you would want to put it. So it is a good day, and it's a reflection of what's happening in our world, right? We just had a couple of elections in BC, and we've had one across the border. And so we need to really think about coming together, because this world wants to separate us and keep us apart. And so we're all in these little boxes. So this is a good thing. So I'll get you to stand, please. So I want you to take a nice deep cleansing breath throughout your whole body. Nice deep cleansing breath. So as we focus on our breath, how many times do we do that ever? Like we get up in the morning and we have our routine, but do we ever just stand still just for that moment in time and take that breath into our body and acknowledge ourselves so that we start our day in a good way? It is about self-care, and how many of you practice that self-care? It's so very, very important, especially in this day and age, to be grounded, to be focused, to come together here and to focus on what you'll be talking about rather than in yesterday or in tomorrow, which basically at this point in time is non-existent. We are coming into a very solemn time this weekend. We have Indigenous Aboriginal Veterans Day on November 8th, and we have the Worldwide Remembrance Day on the 11th. And so do we think about that and what our veterans did for us, those who have passed and those who are still alive? And I know yesterday at the college we had an event, an Indigenous Veterans Day remembrance, and thinking about those days in the past when our veterans were. Hello. So anyways, with Indigenous Veterans Day, when our people went across to Europe, they were heroes over there. And then they came back after the war, and guess what happened? They were disenfranchised and their status taken away, and all of a sudden they became non-Indians, if you can imagine. They weren't allowed home, they weren't allowed on the reserve. Their families were kicked off the reserve, as a matter of fact. And so here we have these people who were acknowledged for what they did in Europe, and they come home and they were second-class citizens kicked to the side of the road. So we have to bring awareness to that. And generally speaking, all of our veterans that went to war for us so that we could have democracy, and how they came home and were disrespected and not supported by our government. So we really have to stand grounded and support those that couldn't support themselves. They ended up being homeless and all sorts of interesting things happen to them. And so it is a day of remembrance, and hopefully we can all participate in that. But considering, we've come to here together to collaborate, build relationships, and that's the key to these next few months, is that we need to support whatever we're in. And really, in fact, you all become leaders in whatever aspect you are. You could be a student, or you could be an instructor, or you could be a CEO, but you are leaders with burdens on your shoulders. So that means take care of yourself, ground to Mother Earth, because who gives you the energy? Mother Earth does. And our environment is so important in this day and age, our water, our air. Did you see the news this morning about India and the smog and pollution that they have to walk through? Do we realize how lucky we are here? How privileged we are here? We never think about it. It's just an expectation. But we are so lucky that we have that clean air and clean water. And we need to protect that here. So each and every one of you have to be part of the parcel. We, the Clayton Tenay Nation, have been on our traditional lands over 9,000 years, as supported by the evidence. The changes that have taken place over thousands of years supports the enduring strength, courage, and fortitude of our peoples. And that line there is so important, because we're still here and we will still move forward, even though we have many challenges. Our governance of the Badlands brought balance and harmony with our brothers and sisters of other First Nations people. Lately, Tenay's clans are Frog, Wasilyu, Grouse, Vinsut, Favorite Sa, and Bear Sus. Through this system, we know who our family connections are. Through our oral history, the use of legends told of our travels, our hunting and fishing territories, our trading practices with all peoples. May you remember to hold steadfast in what Creator's blessed us with, and that is our traditional territories. Our ancestors have always welcomed people to our territories. On behalf of Lightly Tenay's elders, our youth, community members, and chief and council, it is absolutely our honor to welcome each and every one of you to our traditional territories. All my relations, let's see, thank you.
Thank you so much for those opening remarks, Elder McIntosh. And I echo, I feel lucky, as an associate professor in the School of Nursing at UNBC, I feel lucky every day. My mentor there, Dr. Martha McLeod, I was lucky to meet her. I was lucky to connect to Northern Health, to have those connections. And so everything I am today is because many people at Northern Health and Martha saw value in me when I was, just emerging out of my graduate studies, and found a family and a home here at UNBC and with my colleagues and my partners at Northern Health. So it is now my pleasure to welcome the President and CEO of Northern Health, Cheryl Panessa, to provide some opening remarks. So please welcome Cheryl.
Thank you, Shannon. Howdy, everyone. And yes, it's great to be here on the traditional unceded territory of the Lheidli T'enneh, and really always appreciate following Darlene with just your welcome, acknowledging the traditional territory, and then also just your calming presence and the way I feel after listening to you speak. So thank you. And happy to be here today to help kick things off on behalf of our board chair, Colleen Nice, the board of directors for Northern Health. And I know there's lots of Northern Health staff here as well, but on behalf of all the Northern Health staff and medical staff across the North. And, this kind of day, the Education and Training Day, boy, I'm screwing things up. Let's put all the things away so I can't cause any problems. Shannon's probably like, oh my gosh, what is he doing? Is really a fruition of our memorandum of understanding between the two organizations, between UNBC and Northern Health. And, you know, the organizations now, long before me here, I'm really now only have an opportunity and privilege to steward things in this role, building off of many other people before me, in terms of the great working relationship and long history of partnership between the two organizations. And the first MOU was signed in 2010 and was renewed most recently in 2022, just before I was appointed into the role, and does have some money behind it as well, which is always helpful. And you know, we need that kind of resourcing to back this kind of partnership and to support the great things that the two organizations can do together. And I know there's no one in this room, I think, that I need to convince in terms of the enhanced capacity to engage in research within Northern Health. The partnership we have at UNBC just has tremendous positive implications, especially around the impact on health equity, which I'll speak to some things that come top of mind to me shortly here. Just back to the MOU, as many of you know, it has 4 key streams of work that the two organizations have identified as priorities: health and human resources, research and knowledge translation, cultural safety and addressing anti-Indigenous racism, and communication and collaboration. And so it was great just being in the other area there as people were gathering some food, just to see so many familiar faces. There's a lot of brain power in this room, and quite humbling. And I know you've got some great speakers, some arguably world-renowned figures in journalism, research, and implementation science to support the dialogue and learning today, which is great. And as we continue to build a thriving healthcare system here in our unique Northern BC context, this kind of day really serves us well in terms of creating that thought-provoking discussion and dialogue, supporting creativity, imagining how we can do things in different ways to better support service for people and care. One of the things that's very humbling for me being in this role is, you know, getting to play a part, again, building on others to that journey that Northern Health has always had since it's been formed, in terms of being committed to excellence and being a leading health service delivery organization, especially as it pertains to serving people in remote and rural contexts. And we know that engaging in research has that direct benefit to quality of care that patients receive. Julia was, as she was engaging me about coming to make the time to connect with you all today, was just telling me about the latest research that Annette Boas and her team did in the United Kingdom that was published this summer, just articulating the link between participation in research by healthcare organizations and staff and improved healthcare performance. So, you know, this kind of day does create that great opportunity to challenge the norms and figure out how we leverage research, innovation, to make improvement into the future. For me, the top 3 things that come to mind for me around what a strong and supportive research environment in Northern Health and this partnership can do. 1, no doubt in my mind, it contributes to workforce sustainability, and kind of in 2 ways. It allows us to attract and retain clinicians who are interested in pursuing research and research interests, and And then the second is I do feel strongly the partnership we have with UNBC, the ongoing building of research and support that, and the more that we pursue becoming a learning, research, forward-thinking health service delivery organization improves our reputation abroad. And it really does set the stage for people to want to come and work for this organization and our culture and what we believe in and what we aspire to, and people to feel proud to work in and be part of Northern Health because of what that means around how we engage and think about research. And then, of course, the impacts to health equity that I referenced before, and that really boils down to ensuring that Northern residents can benefit from research and that we have research results that are representative of people who live in Northern BC and not be, the reality of most research affects people in urban environments, doesn't represent First Nations and Indigenous people. And then, of course, the connection that we have with UNBC being a research forward-thinking organization just shifts that continues to shift culture in a positive way so that we are an organization that's really focused on evidence-based and data-informed decision-making as a government body. So just again, as CEO for Northern Health, hope you really have a great day. I was saying to a few others as we were gathering in the theater, I definitely have FOMO, having to leave you all here shortly and knowing the great discussion and learning that you're going to have, and hope you have a great day. So thank you very much. Thank you, Shannon.
Thank you, Chiro. The partnership between Northern Health and UNBC is really important. And it's together that we can make that impactful change. So next, it's my pleasure to introduce Dr. Jeff Payne, who is the President and Vice Chancellor at UNBC. So please welcome Jeff.
Thank you very much, Shannon. First, I would like to acknowledge that the event today is on the traditional territory of the Lheidli T'enneh. Very respectful of that important relationship we have. Also, as professionally as the president and what that means to UNBC and how we uphold our commitment to truth and reconciliation, but also for me personally and my own journey here being in Northern British Columbia for 20 years and be a guest on these traditional lands. I'd like to thank Elder McIntosh for her words. Always sets us off. I always learn something every time I have the chance to listen to her and welcoming us to the traditional territory. So thank you. Echo the comments of Chiro. I'll make my remarks brief. Nobody is like, okay, we need to get the remarks out of the way so we can actually get to the business of why you're all here today. But I'll reflect back. And Martha, seeing you here takes me back. The conversations that Martha and I had before the Health Research Institute was even founded, and those initial conversations, and here we are today. I don't want to do that. That's too long. Sometime into the future, and it's so great to see coming together for an education day. I'm a firm believer, as Chiro said, and echoing his comments, of the value of research and the continuum of research to scholarship to improving patient outcomes and improving healthcare. And today is days that are really important where we know that healthcare is going through its challenges. And so the opportunity to come together, to think differently, to add new lenses in how we view things is going to make things better, not only for the organizations and how we work together, but also for the patients that will benefit from that. And so I think it's really important. To Shannon's comment, today is Make a New Friend Day. You really need to take the time to meet with people who are new or reacquaint with people you haven't seen in a while. One of I would say, the double-edged swords of conferences and days like this is we come together with so much energy and passion, and we leave so invigorated, and then we get back to the day-to-day life of our sitting in front of the computers and whatnot. So I encourage you and to think of this day as not a day, but as a continuum of a day to a week to a month to the where we want to go. The partnership with Northern Health is extremely strong, and it has been strong for many years. It predates myself and Shiro. Many have had their fingerprints on this important partnership. I will tell you, we should not take this partnership for granted. This is one of which the province and people here are envious of the partnership we have between UNBC and Northern Health, because I think we put our organizations aside and we focus on what we're trying to do, which is in terms of research and better outcomes for patients. So I'm excited at what we've been able to accomplish over the years, and I know the future is extremely bright going forward. What a great program. One of the downsides of being president is I don't get a chance. I've got to rush off to yet another meeting. So I would like, sure, we'll have FOMO today in terms of what an amazing day it looks like. Appreciate the opportunity to say a few words, Shannon. What a fantastic program. And I do wish you all the best for your day. And remember, it's not a day, it goes forward. So thanks very much.
Thanks, Jeff. You know, UNBC is an incredible place to work, study, and research. And it is such an honor to have that collaborative partnership with Northern Health, because it means the work that we do can actually really make a meaningful impact here in the North. So before I introduce our plenary speaker, and I know you're all excited to hear from him, as am I just want to give a big thank you to our speakers, our planning team, and our volunteers who have worked tirelessly to make this day possible. It was a team that made it work together, so let's give them a round of applause. And you know, when Jeff said it felt like yesterday when he and Martha were cooking up ideas for the HRI, it feels like yesterday Fraser and I were having conversations about, wouldn't it be great to have an education and skills training day? And here we are, Fraser. So from simple conversations, you can make great things happen. So thanks, Fraser, for always being a wonderful partner in all of the work that we do here in the North. So next up, yeah, let's give a round of applause to Fraser. So next, it is my great pleasure to introduce André Picard. Before I go into the regular bio, I had the pleasure to listen to you speak at the British Columbia Public Health Association conference last year, and it was amazing to just listen to you and your thoughts. I found really inspiring, and so I'm so grateful that you agreed to come and share your remarks here with all of my colleagues, friends, and health partners in the North. For those of you who don't know, André Picard is a veteran journalist and health columnist. He's one of Canada's top health and public policy observers and commentators, and he's been part of the Globe and Mail team since the 80s, where he is a health reporter and columnist. He's also the author of 5 best-selling books, and I can say, honestly, I really thought your latest book was really thought-provoking, and I, and along with others, have read it and really, you know, made us think. And I think that's what a good opening plenary speaker does. Makes you think, makes you question, makes you, you know, contemplate things a bit deeper. So André was named Canada's first public health hero by the Canadian Public Health Association, and also a champion of mental health by the Canadian Alliance on Mental Illness and Mental Health. So we are so privileged to welcome him here today to reflect on the state of Canada's healthcare system and how it can be modernized and reinvigorated. So please welcome André Picard. Just mute the screen so you're not. I'm sorry, please don't. We're also not recording. There, okay, better? Okay. Sorry.
We are always beholden to technology.
Okay.
So thank you for the kind introduction, the invitation here today. One of the great joys of my work is I get to travel around the country and actually around the world to visit different health systems and to learn. And I'm always struck by two things. One, the dedication of health workers across the board. It's something that exists in every country, and that you all have so much in common. Northern BC, Northern Sweden, where I was recently, same issues, same day-to-day challenges. So we can all learn from each other, and the common solutions are something we can all benefit from. So it's always great to get out of the office and get out to the real world. Now, you may have heard that the other thing I have to say is holding this mic is going to be a real challenge for me. I'm French. We speak with our hands more than our mouths. So I'll try and not do too much of this, but it will be a challenge. So you may have heard there's a crisis in Canadian healthcare. And certainly if you read or watch any media, you know that. It's collapsing. We hear that word. 1 in 5 people don't have a family doctor. ERs are overflowing, closing with increasing frequency. Can take 8 hours to get an ambulance. That's in the city, never mind out further remote areas. It can take months or even years to get a referral to a specialist, never mind the surgery. Doctors are burning out and closing their practices. Nurses are leaving in droves. Care aides are jumping at the opportunity for better work at Tim Hortons, where they have better pay and better benefits. We're kicking people out of hospital and sending them to nursing homes against their will. Long-term care homes have become killing fields. Oh, and we still use fax machines. There is indeed a crisis in Canadian healthcare, a long simmering one that's boiling over in the pandemic era. But paradoxically, the message I want to deliver this morning is a positive one. God knows we need some positive news. In every crisis lies opportunity, is one of the famous Einstein sayings. I think we're getting tantalizingly close to that tipping point where politicians and policymakers can no longer afford to keep sitting on their hands. Where we're going to have this tipping point where things start changing and they change rapidly. They have to act and they have to take big actions. Now, it's true there are many challenges, and I'll go through them, some of them. We don't have all day, so only some of them. But the important thing to remember is they're all solvable. We spend more than enough time cataloging our problems. We have to now focus on solutions. That's what days like today are about. If you retain only one thing from what I say this morning, let it be this: everything is fixable. I go to a lot of conferences, and I know that you only ever remember one thing from the day. So remember that everything's fixable, and work today on finding solutions. In fact, the principal way to fix the problems in our healthcare system is more collaboration between researchers, clinicians, and policymakers. That's why I'm attracted to an event like today. I get a lot of invitations, and I'm fussy. I tend to pick about where I go based on the topic and the location. And I love the North. I was brought up in Northern Ontario, so never pass that up. Now, the good news is every problem we have in Canadian healthcare has been fixed at least 10 times in a pilot project. We are, as former Health Minister Monique Bégin said, the land of pilot projects. That's what, when I travel around the world, that's what people know about Canada. Don't you guys do all those pilot projects? What we need to do, though, is stop our habit of serial, small-scale innovation and innovate on a large scale. Scaling up is our challenge, not knowledge. It's not time to throw in the towel. I think it's time to be more bold and more hopeful. And what gives me hope in these seemingly hopeless times is that we have so much good advice on how to reform the health system, and so many good people who are able to do it if we unshackle them. In fact, if there's one thing Canada does better than any country in the world, it's catalog the failings of our health system. There have been dozens upon dozens of studies about how to fix Medicare. Started in 1964, a couple of years after Medicare began, and we do them quite routinely. Every one of those reports features a long list of recommendations. Unfortunately, most of them have not been acted on. The principal problem we have is not lack of solutions, it's lack of implementation. I did this a lecture series for Ideas a few years back, and that was the headline they put. Canada does not have a healthcare crisis, it has an implementation crisis. It was a good choice of headline. We don't have an absence of ideas, but a failure to act on those ideas. And again, that's why I love seeing your focus today on implementation. Now, we in the media write about the horror stories, the patient who waits 72 hours in the hallway, the rape victim who's turned away from a hospital for lack of nurses, the town without a doctor. But there are many ERs with reasonable wait times. There are towns successfully recruiting doctors. There are magnet hospitals where they never have trouble recruiting nurses. There are health clinics having a dramatic impact on their communities. There are health teams reinventing the way medicine is delivered. So here's my pithy recipe for success in healthcare reform. Let's start scaling up our successes and stop perpetuating our failures. In Canada, we have this nasty habit of when something doesn't work, we do more of it. We throw more money at it. I think you're familiar with the idea. Now, there's no lack of innovation in Canadian healthcare. In fact, we see innovation every single day because every health worker has workarounds that allow them to actually deliver care in spite of the administrative and systemic barriers to doing so. Nowhere is there more innovation than in the North. Necessity is the mother of invention, as the saying goes. We see a lot of keen young health workers bringing new energy and ideas to the table, at least until we beat it out of them. We've got to stop the beating. Every problem we have in Canadian healthcare is structural and administrative in nature. We don't have medical problems. We have wonderful medicine. We have great health workers. We actually have great health administrators too. But we shackle them. There's too much political micromanagement. Our biggest problems are access problems, and those are equity problems. Not a problem of technology or of medicine. It's a lack of courage about fixing what we know needs to be fixed. Now, I'm going to talk about these things in a little more detail, but I want to step back for a moment and talk about COVID-19. And this is the part where people usually all get up and leave the room. But I think it's important to reflect on the impact that COVID has had on the system and that it has not had on the system. The pandemic did not break Canadian healthcare, as some people claim. It was already broken. The cracks have been expanding for years. What COVID did was shine a harsh light on some of the darkest corners and underscore what needs to be fixed most urgently. Now, you referenced my latest book that I wrote, and this is what I focused on during COVID, was the impact on elders. It was, well, I'll talk about it more. You know, Canada has recorded to date more than 60,000 pandemic deaths. I know we stopped counting, we've stopped writing about that, but they click up every day, a few hundred every week in Canada. About half of those deaths occurred in congregate settings, mostly long-term care homes. Most of the remaining deaths were and are elders living in the community. In other words, almost everyone who died of COVID-19 has been over the age of 65. We need to ask ourselves why. It's not all about biology. It's not because they were going to die anyhow, as many people claim. That's the one claim in COVID that drives me most crazy. People were not going to die anyhow. The average death rate in a nursing home, an average nursing home is 1 to 2% a month. During COVID, it was 30, 40, in some cases in Quebec, 60% of people died in the nursing homes. This was a massacre of neglect. There's no other way of putting it. It's not just the number of deaths that's disturbing, but the way people died, often alone, frightened, and even without the most basic care. We seem to have forgotten this too readily, but some residents of nursing homes died of dehydration and starvation in Canada in 2020. They were abandoned, and I think that's unconscionable. And we owe it to ourselves to not forget that. They didn't just die of COVID infection. There was a lot of collateral damage in the form of isolation and loneliness. I lost a father-in-law during COVID. He didn't die of the virus. He died of being locked up for months and years on end. He died of a broken heart and being alone. Almost all these deaths were due to poor policy choices. We didn't take infection control seriously in care homes. We didn't put an iron ring around them, as one premier claimed. We didn't even put a paper ring. Elders, their care providers, and caregivers were the last to get personal protective equipment. We put all our efforts into protecting hospitals, at the expense of other institutions that were at greater danger. We locked out loved ones, a well-intentioned but ultimately disastrous policy. It robbed residents of human contact and did nothing for infection control because workers still had to come in and workers had to work in multiple facilities. Many other elders locked themselves in their home in fear. These are all examples of ageism that's baked into our public policies. During COVID-19, that proved lethal, but it does in everyday life as well. There's been a lot of gnashing of teeth about the horrors that have unfolded in long-term care. But for the most part, politicians haven't proposed any changes. If we had another pandemic today, would anything happen different? Probably not. They simply promised to build more long-term care homes. This is the classic Canadian response. As I said earlier, something doesn't work, let's do more of it. Does doing the same thing over and over again ever deliver different results? That's a rhetorical question, but. So how do we do things differently? First of all, I think we have to stop our piecemeal approach to reform. For example, we can't try to fix long-term care in isolation. The only way to fix long-term care is to make more home care available. And if you want more home care, you need more community-based services, starting with supportive housing, support for caregivers, and better primary care. It's all connected. Again, that's why collaboration is important. Nothing operates in isolation. We have to rebuild from the ground up. And if we're smart about this, fixing elder care could be a template for reforming the larger health system. Because let's not forget, the vast majority of care is provided to older Canadians, those 65 and over. And I'm almost in that demographic. But this isn't a bad thing. We often blame seniors for using care, but it's totally appropriate and expected. The problem is the system isn't built for them. It's built for acute care, not for people with chronic illnesses. Both our health delivery and health funding models were built for a 1950s demographic, not for a 21st century demographic. Now, the message I've been repeating for the past 20 or 30 years or so is devilishly simple. The problems we have are largely systemic, so we have to fix the system. It seems self-evident. We need to stop talking about it, stop pointing fingers, stop passing the buck, stop blaming patients, stop blaming doctors, nurses, politicians, bureaucrats. We all have to roll up our sleeves and fix it together instead of pointing fingers. So where do we start? I think we've lost the plot a bit, so we have to get back to some basics. We need to ask ourselves some really big questions, and I hope some of these will come up in your discussions today. How do we ensure that every Canadian, regardless of where they live, how old they are, how much money they have, gets the right care in the right place at the right time? That's essentially our goal. How do we structure our health and welfare system so that everyone can live to their full potential? Not equally, but equitably, fairly. And how do we, in all our healthcare interactions, prioritize quality of life, which is ultimately what matters to each of us individually. Now, the good news, again, is that we have the answer to all these questions. As I mentioned earlier, we're world champions in studying the shortcomings of the system. A few years back, maybe a decade or so ago now, I wrote a book about the history of reform, or lack thereof. As part of that research, I read many of these reports. And at a certain part of this painful journey, if you have problems with insomnia, I could recommend some reports. But yeah, as part of this painful journey, one night I had this epiphany. I realized that they all say more or less the same thing. Since 1964, we've pretty well written the same report over and over again. I took the hundreds of recommendations, I put them into an Excel spreadsheet, and realized there were really only a handful of truly meaningful measures that needed to be done to reshape and rejuvenate the health system. So I boiled them down to 5 or 6. Number 1, primary care. The foundation of every good health system is primary care. But in Canada, it's the weakest part. 6.5 million Canadians don't have a primary care provider. When you build on a shaky foundation, everything else risks crumbling. And that's what we're seeing today in the real world. In an aging society, we need to move away from an acute episodic care model to a chronic care model. Until every Canadian has a medical home, the way every Dutch person has in the Netherlands, someone who's ultimately responsible for their navigation through the health system, the system will always fail. All the technology and all the money in the world will do nothing if millions of people don't have a primary care provider. Now, this issue is finally being taken seriously in Canada, but it's decades overdue. But I'm really looking forward, for example, Jane Philpott was just appointed by the Ontario government to ensure that every Ontarian has a family practitioner. It's going to be a big challenge, but if she's successful, hopefully this will spread across the country. Number two, every report for the past 60 years has talked about the importance of community care, treating people where they live, not only in warehouse-style institutions like hospitals and nursing homes. These institutions are important, but they take up too much space. Our system is too hospital-centric. Again, community care is largely about providing the basics, primary care. We're not going to train thousands of family docs overnight, so we need to create teams of healthcare providers and provide them with administrative support. Again, it's about your theme. We need more collaboration, more teamwork. We have to change medical education as well. To me, the key to improving medical education is focusing on interdisciplinary care, training healthcare workers together so they can learn to work together in the real world. We have to break down the hierarchies. Number three, drugs. For 60, 70 years, we've been talking about the need to extend universal health coverage to prescription drugs. That was the number one recommendation of the Hall Report of 1964. It's part of the unfinished business of Medicare. Now, 2 weeks ago, the pharmacare bill passed. In Canada, we're now going to theoretically fund oral contraceptives and some diabetes drugs, but only if provinces sign deals. BC's at the forefront, they're ready to sign a deal. But still, this is baby steps. What about everyone else who doesn't have access to their drugs? We have to fix them. And that doesn't mean covering everything for everyone at all times. It means getting the basics to everyone. Number four, every report has talked about the importance of the social determinants of health, something that's become more in vogue to talk about since the pandemic. We need to invest in prevention efforts, particularly for socially disadvantaged and marginalized groups, such as Indigenous peoples. But above all, we have to stop pretending that health is merely a medical issue. What really matters to our health is having a decent income, a roof over our heads, a good education, access to healthy food, a healthy environment, social connections. All of these things need much more than medicine. We have to stop waiting until people get sick and then sticking them in a queue. 95% of our health spending in Canada is for sickness care. Only 5% goes to prevention. Obviously, that's out of whack. Number five, human resources. Health needs to be a hands-on, people-centered business. We have to make sure we have the right mix of health workers and a good work environment. Staffing is without a doubt the number one challenge in healthcare today. Those of you who work in administration know this. This is what keeps you up at night. How are we going to have enough doctors and nurses and care aides to take care of people today? We have to do better at recruitment, but mostly we have to do better at retention. The number of people leaving is a tragedy. The only way to do that is to fix the workplace. And that matters to patients a lot too, not just to workers. As sociologist Pat Armstrong famously said, the conditions of work are the conditions of care. The workplaces in Canada are in many instances toxic. We have to stop throwing more bodies into the meat grinder and fix the workplace. You can't deliver good care if you treat workers badly. That's one of the big lessons of COVID. And workers, from personal support workers to nurses to physicians, aren't going to stick around if you don't take care of them. There's too many opportunities out there. We saw this demonstrated graphically during the pandemic. The areas where health workers are most desperately needed, primary care, geriatrics, community care, are the ones with the most severe recruitment and retention problems. And to me, this speaks to profound structural problems. Of course, there are many, many other things that can be done in health reform beyond those 5 areas. For example, we need to make better use of technology, an area where Canada is a terrible laggard. Our electronic health records are poor at best, with the lack of interoperability being one of the principal problems. If you go into an emergency room, it's unlikely your family doctor will know it. If you fill a prescription or you don't, your GP or specialist often has no way of knowing it. Now, some provinces are better in this than others. Again, BC, I think, is a leader with drugs, for example. There's a good connection, but these issues vary a little bit from every province and every region. The more fundamental problem is that in the age of AI, we're still using paper records and fax machines. Fax machines were literally invented in the 19th century. They've been around for 150 years. They need to be retired long ago. They're even older than me. But of course, issues like technology fit into my big 5 categories that I just talked about. Technology like EMRs are essential to good primary care, which depends on navigation. Every one of the big fixes I mentioned also applies specifically to elder care, which again, I think should be the priority. If we can do a better job of delivering primary care, we can delay the need for tertiary care. If we do a better job of rehab, we can avoid institutionalization and so on. I'm just repeating this message that everything's connected. We need to invest in more and better in the community-based services beyond the medical, from home care to supportive housing to practical services like Meals on Wheels. We used to have departments and ministries of health and welfare. We seem to have forgotten the welfare part, and that's, again, a tragedy. For older people, the default setting should not be that you go off to an institution when your health begins to decline. The default setting should be that you stay in your home as long as possible, and that institutionalization is only a last resort. To me, that's what distinguishes countries that deliver excellent elder care from those that don't. They've decided, as a matter of public policy, of ethics, that elders matter, that having them as active members of society matters too. That's why I'm a big fan of Denmark. I go there often. It has really the gold standard of elder care. They deliver better care than us, not because they spend more money, not because they're smarter, but it's because they've made quality of life a priority. When I go to somewhere like Copenhagen, you walk down the street, family home, nursing home, family home. They look like real homes, and people live in them like they're their homes, not institutions. Even people with advanced dementia, when I visit these homes, are helping cook their own meals. Everyone contributes to their abilities, and everyone draws what they need. And they live in a family setting. Denmark is another example of a country that does a lot of things that are counterintuitive. In the 1980s, they decided, we're not going to build any more hospitals, no more hospital beds. They haven't. The number hasn't changed for 30 years. And guess what? They have fewer lineups in the emergency room than us. They don't have overcrowding. They invested heavily in the community rather than bricks and mortars. Denmark has great home care. And it also has, as I mentioned, great long-term care facilities. But they're different. They're small. Every one of them is paired with a daycare or a primary school right next door, so that elders and children can interact, so they can be part of the community, so the kids grow up knowing that it's normal for people to be old. In Canada, we hide them off in buildings down the highway. We should see people every day in our lives who have dementia and so on, because that's the reality. I was in a grocery store the other day near my home in Vancouver. A woman came up to the cash and she took her food and she just walked away. And one of the other clients said, aren't you going to make her pay? Oh, never mind. She comes in here every day. Her daughter will come back later and pay. We know her. That's Mark. And she was in her bathrobe and her slippers, but she got her food and off she went. That's how it should be. People should be part of a community and known in their community. Our care homes in Canada are more like prisons than they are homes. Now, innovation is not about fancy gadgets. It's about a different way of thinking. That's the message I take from countries like that. Denmark prioritizes and rewards innovation. When an institution there has an innovation that improves patient care or that saves money, it's automatically scaled up across the country. And then they're rewarded with additional money to do more research. That's how you get innovation. You value it and you invest in it. Imagine if we did that here. You have a good idea, everybody's going to do it. To me, that's the problem with our pilot projects. I don't think any pilot project should be funded unless there's an upfront commitment to institute it if it meets really severe targets. If it works and it really works, do it everywhere. There's no excuse not to. Otherwise, you're just throwing your money away. Now, with a thought process like that, it's not surprising that Denmark's a leader in digital technologies, such as telemedicine and assistive devices. They even have electronic medical records that are national, include everything from prescriptions to ER visits to nursing home to social welfare information. And they've had that for 30 years. Who knew that was possible? Even Belize has national health records, a tiny little country in Latin America. Of course, a commitment to innovation requires a couple of basics, like good data. In Canada, we have quite a horrible data gap that hinders not only reform, but the delivery of good care. My paper has been, in the last couple of years, on doing a project about the gap in health information and our obsession with secrecy in Canada. And currently we're focusing on the health system. It's quite disturbing how secretive we are. Again, I like to travel a lot to the Nordic countries. Take a country like Sweden or Norway, even people's tax returns are online, easily visible. There's no secrecy, and that's data that they do have and collect, they use smartly. We don't do enough of that. Now, for the most part, we don't lack data because we collect it by the truckful. Recently, I was reading a study that said that for every hour a Canadian doctor or nurse spends with a patient, they actually spend 2 hours on data entry. That's not what people should be doing. Doctors should be doctoring and nurses should be nursing. They shouldn't be data entry clerks. Now, AI may help a little bit with this, might lift some of that burden of paperwork, which is actually the #1 reason for burnout and the #1 reason people leave the profession. Too much paperwork, too much bureaucracy. I did a story recently about AI scribe. So you sit down, the patient talks to the doctor, no more staring at the screen, no more clicking. Instead of, you can actually look a patient in the eye, talk to them, and the scribe automatically summarizes the conversation and puts it in the medical record. And it's really amazing how accurate it is and how good it is at weeding out insignificant things. So I was doing this mock visit with a doctor, got the diagnosis, but I was doing things like, "Hey doc, how was your holidays?" and stuff. It just ignored all that. It focused really on what was essential. It provided a prescription. I made sure I had something that required a prescription automatically sent to the pharmacy, the summary there, the summary for the patient, a follow-up text to tell me the 2 things I had to do. This is amazing technology that we have to embrace. And we have to not make the mistake we made with electronic health records. We have to have centralized systems that everyone can use that are interoperable, not a mishmash of stuff, homemade garbage to really good systems. We have to really think and embrace the AI mindset and do it quickly. In Canada, I think we have some pretty twisted ideas about privacy. Time and time again, I hear privacy zealots railing about the dangers of electronic records and the horrors that await us with AI. But they think it's okay to have unlocked rooms full of paper files that anyone can access. Or they shrug off the stories that we write these stories several times a year about patient files being left by the curb when a doctor closes their practice. Not to mention how much time and effort we waste collecting basic information over and over again. My mother had chronic illnesses like COPD and eventually dementia, and that's the one thing she hated the most, just telling her story over and over again. And she lived in a small town in Northern Ontario. They knew who she was, but we had to go through the clipboard, read every 15 questions. She hated that. The other thing about clipboards is that's another industry that shouldn't exist, but it exists only because of healthcare. because we give everybody a student deal. Another aside, little irrelevant things I know. And again, I think the biggest tragedy, though, is the little use we make of the data we collect. For example, we have a decentralized model of healthcare in Canada. We actually have 15 different health systems. This is not great, but it's a constitutional, something we're stuck with. The very least we should do is use it as a natural laboratory. Let's compare between jurisdictions that do things differently, see who gets better results. But do we do that? When's the last time you saw a meaningful comparison of health outcomes between provinces or even between regions? We don't do this because it makes our politicians look bad, so they quash it. We had briefly something called the Health Council of Canada, which actually did this. It did these great interprovincial comparisons. The provinces cut off the funding because it made some of them look bad. That's not the way to have a health system run. We should learn from our mistakes and learn from our successes. Research should not be stopped because it hurts some people's feelings. Quite the opposite. Now, this is all the more important because data is going to be the cornerstone of medicine in the future. Everything from genomics to artificial intelligence to AI requires little bites of information, lots of them, to be parsed in this continuous feedback loop. That's the future of medicine, personalized care based on your data. And again, we can't do this with fax machines. We can't do this with systems that don't speak to each other. But there are little glimmers of hope out there. During COVID, for example, we saw a dramatic increase in the use of telemedicine. We made about 20 years progress overnight. And how did we do it? We did it out of necessity. Provinces changed billing codes so that doctors got similar remuneration for in-person and virtual visits. Magically, overnight, something we were told was impossible became possible. There's a lot of those little fixes out there that can be implemented. Now, what's sad about this happy story is that, like many innovations in Canada, the changes were largely temporary. We've mostly gone back to our old ways of doing things, to old billing codes. Again, seems to be the Canadian way. We regress to the comfortable instead of striving for excellence. That's why I often describe Canadian healthcare as islands of excellence in a sea of mediocrity. Now, you heard the president early on saying his frustration is he gets to open a lot of conferences but not stay. My frustration is I go to a lot of conferences and I know I'm speaking to the converted. I know the people who really need to be in this room aren't in this room, and that's sad. But you have to find a way of bringing them in, for sharing this info. Now, before I finish, I want to say a few words about education, the education of health workers. What I want to do is sort of share my impressions as an outsider, as a longtime observer of healthcare, and someone who interacts with a lot of health workers, from students right through to wily veterans. I think I probably visit all 17 medical schools every year in this country. Soon there's going to be 20. And I'm always, that's where I get my hope, is from talking to the young students in medicine and nursing and other health professions. They're still hopeful, and we have to help them hang on to that. But I think our medical education system, like our health system, is outdated. We really need an injection of interdisciplinarianism, if I can use that word. It's a made-up word. Schools of medicine, schools of nursing, social work, physio, occupational therapy, often and too often operate in splendid isolation with too many hierarchies, mostly implied hierarchies. We assume doctors are up here. They shouldn't necessarily be. I wish I could carve these words over the entrance of every medical school. No doctor is an island. They can't work without other health workers. The other observation I'll make is that I'm not sure we're always attracting the right people to the health professions. To me, the two most important traits of a health worker are empathy and an ability to listen. Yet we put far too much emphasis on marks and far too little on communication skills and basic kindness. Personally, I don't care if a doctor or nurse got 99% in biostatistics. I care if they look me in the eye and tell me what I need to know. One of the major impediments to healthcare reform is the culture of medicine. It's profoundly conservative, small c. Change is rarely welcome and often actively resisted in medicine. It's a culture impregnated with unhealthy nostalgia. You hear a lot of macho nonsense about the good old days when people worked 48 hours straight and routinely put in 100-hour weeks. That's nonsense. What did that do to their families? How good was that for their patients? And by the way, their patients were a lot easier. The students that are being trained today should not be told that this is a good thing. Quite the contrary. You know, there's intense pressure for them to fall into line and not rock the boat. But that's what we need. We need a lot more boat rocking. I'm not sure exactly how schools can train future healthcare workers to resist the culture, but I know they have to try. Because I think young people are a lot smarter. They really care about things like work-life balance. And we hear people say, oh, look, they don't want to work. Well, good for them. They want to have a life, and that's important. And it's something they should teach their patients as well. Having a healthy life is good for you. You wouldn't be in the doctor's office so often. And we heard that very eloquently from our elder today. The other thing about the healthcare sector, about health education, is our health workforce should look like our population. And it doesn't always. There are many linguistic, racial, and socioeconomic groups that are underrepresented in healthcare, and others that are overrepresented. And we know which ones. The poorer people have more people from multiple backgrounds, the lower paying jobs. To deliver equitable care, we need equitable educational and employment opportunities. Again, it goes back to the workplace. People should look like you. You feel more comfortable. I think some of the teaching methods are outdated too. We teach a lot of stuff, often by rote. And by the time students learn and graduate, a lot of their learning is out of date. We need to teach people how to keep learning, how to adapt rather than what to learn. And again, conferences like this are really key. We need to teach people how to keep learning throughout their lives. This is becoming even more important in the era of big data and artificial intelligence and machine learning. We have to equip people with adaptive skills and teach them resiliency. In our brave new world, survival skills have to be part of the curriculum, surviving technology, among other things. And I can't stress enough the importance of communication skills. I think one of the big paradoxes that's coming to us very quickly is that the human side of medicine is going to become much more important in an era where machines and robots can do a lot of the tedious and manual tasks. I think it's going to be the golden age of medicine. At least I tell this to my daughter. She just graduated from med school. The future is going to be very interesting. It's going to be more about people and less about stuff. I wonder if we're training health workers too where they need to be trained. We have acute shortages of workers, and those problems are always more acute in rural and remote areas. But if there's one thing research clearly shows, is that if you want people to work in rural and remote areas, you need to train them there and teach them there. You know, all the discussion is about let's open more seats, but it's where those seats are that matter. Our schools are far too concentrated in big cities and on specialty programs. We need to do more of the basics and in all parts of the country. One example for me in my travels was Norway. They have a medical and nursing school that's almost at the North Pole. I think I saw Santa when I was there. I wasn't sure. It was off season, I wasn't sure, but there were a lot of people with long white beards. Canada's an Arctic country too, but we don't do enough of our education in northern areas. And what role does money play in health education? When you charge $27,000 a year in tuition, which is the University of Toronto Medical School, what kind of students will you attract? Certainly not poor ones. My children, thankfully, were raised in Quebec. Their tuition in medical school is $4,000 a year. Much different cohort in those kind of classes than in Toronto. If you saddle students with massive debt, often in 6 figures, What kind of career choices are they going to make? They're going to go to higher paying specialties, not to family medicine. And then we wonder why we have shortages. Now, the last thing I'll mention, because I want to leave some time for your questions and comments, is money. Because of course, you can't talk about healthcare without talking about money. Canada is one of the biggest spenders on sickness care in the world. On average, health or sickness care gobbles up about 42% of provincial budgets, the biggest spending area by far. Last year, we spent, I have in my notes 344 billion, but the new Kai report just came out this morning, 374 billion last year on healthcare, and at roughly $9,000 per capita. Now, a country like Denmark doesn't spend more money than we do. In fact, it spends less. The worst part of Canada's spending is that we get little value for money. And we don't talk about that. We obsess about costs, and we don't talk about value. But my biggest frustration of all is I think we have the least universal healthcare system in the world. Now, I say this publicly a lot, and I always like to repeat it so people can ponder that for a second. The least universal health system in the world. So what do I mean by that? Our Medicare system covers 100% of hospital and physician care. It's done so since 1966. Covers a bunch of other services too, but in a very haphazard, piecemeal fashion. We cover about half of prescription drug costs, about 40% of home care and long-term care, 6% of dental care, and so on. We don't cover hearing aids, we don't cover ambulances, weird things for no apparent reason. Now, universal doesn't mean covered 100% for everyone. It means everyone is covered to some extent. Now, the Canadian standard, which I think is one of the greatest philosophies of the healthcare system in the world, is that no one should be denied essential care because of an inability to pay. That is a wonderful philosophy. The problem is we don't live up to it. In Canada, the de facto definition of essential care is physician and hospital care. It's a 1950s definition of essential. The result is while our system is universal, it's profoundly inequitable. What most European and Nordic countries do is cover about 80 to 85% of all health services publicly, from dental care right through to hospital care. And then the balance needs to be topped up with private insurance, except in rare instances where people don't have enough income. But the lines are clearly drawn. You know, I hear people over and over again say, oh, we should have the health system of Germany or of Sweden or of Denmark. Or, I make this mistake. Oh, it'd be great if we were like the Netherlands. But you can't just import those ideas because healthcare is very cultural. But what you can do is learn from their approach. And I think these countries are not better than us because they have better medicine, because they don't. They're not better because they have an element of private care, because they have less private care than we do when you get right down to it. They're better because they're equitable and they're transparent. People know what's expected of them. In Canada, there's no rhyme or reason to what's covered by Medicare and what isn't. Is 100% of physician care and hospital care essential? Of course not. Conversely, why do we not cover, say, an ambulance ride or a hearing aid, depending on what jurisdiction you live in? The discussion we need to be having today is what's covered by Medicare and what isn't, because we can't cover everything. But what we do instead is sling rhetorical volleys like privatization is bad or privatization is the answer. Neither of those things is true. I believe the one thing we can all agree on across the political spectrum is that publicly funded insurance can't cover all things for all people all the time. There needs to be a mix of private and public funding and private and public delivery. What we should be arguing about is what's the proper mix of private and public? How do we make sure everyone is well served and that we get the best value for money with that mix? That would be a much more productive debate. It might even spur innovation if we ask insurers and providers to make the case for why they're being funded. Do we need to spend more public money on providing essential health services? Probably. But first we have to figure out what we're funding and why. One other point about health spending that rankles me is the pointless and tedious debate about who should pay for what, federal, provincial split, if you will. Of that $374 billion that we spent last year that I mentioned, about 250 billion, or 70%, is public money. That money comes from taxpayers. We shouldn't really care what level of government signs the check. Ottawa currently pays about 22% of the health bill. To me, they should spend more money on healthcare, but only if it expands the Medicare basket of services, only if it helps fix the system, only if it spurs innovation. In other words, only if money is targeted. Now, provinces don't like that, at least in theory. But the thing is, they never refuse money, no matter how many strings are attached. Now, we'll never solve our problems of Medicare by simply doing more of the same, by spending more money. That's not innovation, it's stagnation. The final thing I'll say is when we talk about reform, we always talk about systems and policies. Now, of course, systems matter, and policies matter, but this is ultimately, or should be ultimately, about people, about individuals and their rights and our obligations to them, and their obligations to themselves. We can't let people off the hook. You have some responsibility to take for your own health. We talk a good game about patient-centered and family-centered care in this country. But during the pandemic, those ideas went out the window. At a time when we fundamentally changed the delivery of care, at least temporarily, we completely shut out patients and their families of the decision-making process. We have to get that patient and consumer voice back into the mix, and quickly. People need choice, real choice about where they get their care and how they pay for it. And that's not some cry for more private care. It's about having agency, and we don't have enough agency in our system. And I'm not saying people should be able to buy care or jump the queue. That's not what it means. It means they should have options, even within a public system. So here's my take-home message. We need to reboot Medicare. We need to create a system that we're proud of again. We also have to create a system where workers can take pride in their work, one where carers have time to care. We have to put the joy back into caring. We have the ability to do it. We have the money to do it. We just need to mobilize the political will. We have to heed the lessons of COVID-19, the most important of which was the basics really matter. We have to shore up our crumbling foundation, primary care, and we have to rebuild from there. In the almost 5 years since COVID-19 hit, our world has been turned upside down. But we've not only survived, but in many cases, we've thrived, we've adapted, we've changed. This is an opportunity for our beloved Medicare system to thrive again. After all, a pandemic would be a terrible thing to waste. So I'm going to stop there and welcome any questions and comments you might have.
Need to run the mic and you speak up. Okay, so questions, comments, feedback. I'll run the mic here. And introduce yourself to when you.
I have comments. So my name is Paul Woodward. I'm the Associate Vice President of the Division of Medical Sciences here. You can hear from my accent, I've worked in 3 different countries as a healthcare provider and an education leader, and I've practiced for 40 years. And my main comment is thank you. And it's probably the most insightful talk I have ever heard about healthcare delivery. Truly, and I think I'm going to nominate you to be the next Minister of Health. I'm going to powerless to reform healthcare.
I don't need to be punished that badly.
But actually, I agree with absolutely everything you've said. I truly do. Absolutely everything. I guess my comments are number one, there's a great phrase, which is culture eats strategy for breakfast. And we do need to change the culture, and we need to do that each and every one of us working in healthcare and in research. And so often we get told we can't do this, we can't do that, we can't do that research. And I understand that people are working at the coalface and are busy and they can't see beyond that coalface. But we needed, we had to change the culture every round, and it starts like that, and go to the level. And secondly, I agree with you about systems. Our systems have become incredibly inefficient and wasteful. And yet during COVID, as you say, we showed that we could do things really quickly and efficiently. So, we need to build on it. My third comment is about funding. And I agree with your comments there. I do think there's a lot of room to be more efficient with our use of funding. But ultimately, I think that we're going to have to make some tough decisions about what we can and can't afford. And we talked about Scandinavian countries, and I haven't had the privilege of working there, but I believe their taxation is an awful lot higher than here. And they provide a lot more social and welfare services than many other Western countries. They also have some of the happiest people in the world, but they have a higher tax system, and I think the public may have to accept that they want that type of healthcare. They're going to have to pay for it. Thank you so much. I really enjoyed it too.
I won't comment on everything, except I don't want to be health minister. I do spend a lot of time in the Scandinavian countries because I'm a big fan of their health and social welfare systems. They do pay more taxes, but not that much more, to be honest, when you get right down to it. The important thing is they don't spend more on sickness care, and they don't really spend more on welfare. They just do it more smartly. So I think the taxation thing to me is it's a red herring. It's how you spend the money there, and that's what they do differently. The biggest thing, and people don't like to hear this, is they pay their health workers a lot less. So I was just in Stockholm. I was staying with a friend who's a doctor. He gets paid the equivalent of $91,000 in Canada. He's a doctor. He loves it. And I tell him, if you're a doctor in Canada, we bring home 350, and you'd be a corporation. You'd be a lower tax rate. He's like, I have my job and I do it and I work in this clinic. I don't want to be a small business person. And that's the culture that's really changing. I'm seeing with younger people. When I go to medical schools, they're like, I don't want to run a business. That's the main reason they don't become family doctors, right? And we have to change that. We should have public clinics staffed by, he's a government employee. He's not ashamed of that. In Canada, that's like, oh my God, I can't be a public employee. Why not? I lived in Quebec for a long time. My doctor was a salaried doctor. She worked for the state. Again, she loved her job. She had a pension. She had maternity leave when she had her kids. We have to get rid of this culture of entrepreneurship in medicine, which again is from the 1940s and 50s. So I think these things are important, and the culture one is really essential. We do have to change the culture. I just did a piece. It's the 100th anniversary of the Federation of Medical Women of Canada. I did this long thing about 100 years of how women have changed medicine. It made me realize how profoundly culture has changed. So we can't forget that we're capable of doing this. Women doctors practice very differently. They think differently. Their patients like them more. There's all kinds of, and these are all cultural issues. And again, when I go to medical students, to medical schools and talk to students, they think very, very differently. The world's different for them, and they have to make the medical world different. The impediment is old people like me who say, oh, no, we can't possibly do that. We can't. Well, yes, we can. And we're going to have to, or else we're going to lose them.
My name is Julia McFord. I'm the executive director here for research, innovation, and evaluation at Northern Health. Really excited for your talk, and I recently read your book, and it's just so kind of starstruck that Shannon managed to get in. But again, following the comments, really agree with everything you said, and I think you've given us a lot to think about that we can revisit both the days as well in our workshops and discussions together. I guess one question I would ask you, and not to put you on the spot, but we're here, rurality is a big piece of what we are in the north here, and something that we celebrate. It also makes recruitment and retention a real challenge. I know you've touched on that. And wondering from your perspective, what are some of the key things that we should be thinking about, Northern Health, and maybe also in partnership with community, about how to make our recruitment and retention strategies more effective in the rural context?
I was raised in Northern Ontario, so I love this question. I think it's a really important one. I think you actually have a real benefit in this brave new world that's coming, and that's lifestyle. So lifestyle matters a lot more to young health workers. So that's what you sell. You sell the lifestyle. The biggest impediment to people practicing in rural and remote areas is that they have to work all the time. Like if you're a family doctor, it feels like you're working 24/7. That's what we have to get rid of. We have to say, you know, the mill worker finishes his shift, the doctor, she finishes her shift too. That, once you have that, and then you have the lifestyle, it's cheaper to live here sometimes, depending on where in the north. And well, housing anyhow, cheaper than Vancouver. But you have to sell on the things that draw, you know, why do you stay here? Those are the same reasons that are going to attract people. And then I think the second part of it, the key is medical education. It's like people have to be exposed to this right from day one in medical school. I'm a big fan of NOSM, Northern Ontario School of Medicine, in Sudbury at Thunder Bay. Right from year one, they have placements on reserves. Go see real life, live in the community. They send them to social welfare agencies. Give them a taste of real life and that they can have an impact. And that's the other part of it. You can have a much bigger impact in a smaller community than downtown Vancouver or downtown Toronto. And that's attractive to young people. They're socially engaged. They care about the environment. They care about work-life balance. We have to create jobs that appeal to people's sensibilities. We create jobs that appeal to Marcus Welby. Marcus Welby's been dead for 50 years, right? We're really stuck in the past. I know I repeat this a lot, but it's a key issue. So I think the future for rural and remote communities is actually really bright. I think we saw this during COVID, kind of an exodus from bigger cities, and I think it's going to continue.
I'm gonna go up and then I'm gonna come back. But as I'm walking, you know, I really appreciated your comments about the Nordic countries. Rich and I just went on a trade mission to the Netherlands to be taught about all the innovations in long-term care. And so we came back so inspired of things that we can share. Just wait, Aaron, I got a PowerPoint coming for you. Dementia care, the Netherlands.
My name is Prince. I am the NDMP program. I'll be finishing my primary and will be taking the master's program. Thank you so much for the presentation. I was hoping maybe the presentation is already printed or it's in a book where I can get to read it all the time, but they have a lot of ideas that up and coming healthcare professionals implement or use. But quick question that I have is how do we motivate the political will to be able to help with these challenges that we are facing? Because I think about the COVID-19 crisis that highlighted the challenges of the healthcare in Canada. Like for me, for instance, my wife is just registered, got a registration in Canada as a registered nurse. She was an internationally educated nurse for 10 years. Due to the bureaucracy, she couldn't get registered. And we were just finally this year that she got registered. So how do you motivate? What are the strategies that we can put in place to motivate political will in order to help solve some of these issues that we're facing?
Faster.
I wore my high heels. No running shoes, so.
I would talk without the mic, but I'm not a very loud speaker. So, very important question. I think we really have to streamline the acceptance of workers from other countries. Again, I think BC is a leader on this. They're really trying to do this. But again, it's something that should have been done decades ago. Our health system is full of guilds, organizations that protect who they are and don't welcome outsiders, and that has not served us well. So I think we really have to step up. One of my biggest worries in healthcare today is immigration is falling out of vogue. We have these real attacks on immigration numbers. Our health system rests on the work of immigrants. We saw this in COVID much more vividly than any other time. I was in Quebec for part of COVID. And we called them the guardian angels, all these workers who were temporary workers who kept the system from complete collapse. So I think we really have to, it's important that people meet standards, but this assumption that countries don't train people well is nonsense. A lot of them do, and it's really easy to figure out quickly if someone is qualified, and we have to make that a priority. We have to streamline it. And again, it's happened in many pilot projects. We showed that it's easily done. We just have to do it. Stop this nonsense of protectionism. That's a very important question, and I do worry about us being able to fill jobs if we're going to cut down on and place these unfair burdens on immigrants and people who've worked in other systems.
All right, I'm gonna give Marcelo the last question.
Marcelo Rapid for patient-oriented research, knowledge translation. And I would like to ask you your reflections about, since you've been discussing about innovation, my question is how to work effectively with patients and with users of the system rather than just traditionally inviting to studies, but meaningfully involve them into projects, activities, innovation. What's the reflection of this involved?
I think that's a really important issue. I was just at a conference called Patients as Partners, and I think that the title of that conference is the answer. That patients have to be partners, and they can't just become partners once you got your grant. You have to have them from day one. What do you think we should be researching? We don't ask patients that. I love it. I'm a journalist. I love anecdotes. One of my favorite anecdotes about a research project I wrote about is it's this great research project. They found how to extend the life of people getting liver transplants, and the researchers were really proud. And then it turned, they had a new method, a new drug actually, and then they found out that none of the patients wanted the drug. And everybody's like, well, that's puzzling. This is going to make you live longer. And the patient said, well, it makes me itchy. It makes my life miserable. I don't want this drug. I'd rather be dead than being itchy 24 hours a day. Nobody asked them. Like one of the patients I talked to said, why didn't they ask me what matters to me? Before they started this research. I would have told them what matters to me is my quality of life. I know I'm going to die, right? My liver is failing, and I'm going to die eventually, but I want to live my life for the rest. So that's the key. Get them in on the ground floor. Ask them what they want. Every researcher I talk to who works in that way with patients says it makes the research better. They go, oh, I never thought. You don't necessarily think of what matters to patients. And it's rarely, patients are very, especially people with severe chronic illnesses, that's the kind of patients I often talk to. They're pretty pragmatic and sensible. I'm going to die. I'm not expecting a miracle. I want my life to be better. You heard me in my talk, quality of life. That's what it's about. I read a lot about things like MAID, a lot about people who are dying, who refuse cancer drugs, right? I don't want cancer drugs. I want to spend 3 months with my grandchild, being able to play with them in the park while I'm dying, instead of 6 months in a hospital bed, getting an IV infusion, and this doctor's proud that he kept me alive. That's not life. So I think make them part of the process, and make sure they make you ask the right questions.
Right. All right, so let's say thank you so much for such an inspiring opening. Thank you so much.
So, just a plug for putting patients first is next week's conference in Vancouver for BC Support Unit. So, hey, if you want to learn more, that's a wonderful training opportunity next week. And I know Julia and Marcelo and Leanna and Bree and lots of our patient partners from across the north will actually be at that event, sharing their voices and experiences about the importance of patient-engaged research and having the patients first. So you've given us lots of things to talk about, and I hope that this just starts the conversation throughout the day. And I want you each to think about the role that you can play to help shift the system. And I love, we are stuck in the eternal land of pilots. As a researcher, it is a struggle to get past that small pilot funding actually to spread things that we have shown. But we have great success of that collaboration in the North. We have done amazing things in partnership with Northern Health. And, I see Tina Stredcombe there who, from a small $10,000 research grant and one patient voice, we were able to change policy to support older adults to grow their own food and long-term care, something that they said was meaningful to them. So we do have great examples of that. And it was through health system researcher collaboration. It was through Northern Health UNC collaboration and has spread, Interior Health heard about these innovations here and now that policy impact is spreading across our health systems in BC. So we have great opportunity to be leaders. Our MOU makes us special. And I share that a lot, Erin and I co-present a lot and, our secret to success is we show up to the table together. We work together in partnership. And now Tracy has inherited me as her, I don't know where Tracy is here, but she's inherited me now as her partner. And, Erin from hospice has inherited me as her partner as well. So, getting to meet the right partners for you between health system and university makes us do wonderful things. So what's next? Before we go to our workshop rooms, I want to provide a few housekeeping points. At lunch today, we have two different events. First, there's a service network lunch, and that's held in the conference center, room 6205. So for those of you who really want to talk about these collaborations, meet new people, have that engaged conversations, we hope you will join us at this facilitated lunch. So Julie Moore is actually going to facilitate that lunch. Note for those of you going to the service network lunch is served in the conference room. So you go to the room first for the lunch, you get your lunch there. Secondly, we are so excited. We have Dr. Laura Middleton, one of our morning workshop speakers, is also going to lead a lunch and learn session, which will be provided in the Bentley Center. So Dr. Middleton will be sharing her expertise in engaging in diverse ways. So providing supports through participatory research. So she'll be doing a lunch and learn style in the Bentley Center. Again, if you're going to the lunch and learn, you get your lunch in the Bentley Center. We will have lunch in 2 locations. So go to your room of choice first, and then get your lunch. Now for this morning's workshops. So we wanted to give people choice, right? And what's meaningful to you, there we go. We're already living that. So in the morning and the afternoon, you all had choices of your red or blue tickets. So on the back this morning, your registration people wrote AM or PM on the sessions. So red tickets are for those of you attending the session, selecting effective strategies to address the barriers of facilitators to change. That's being led by Julie E. Moore from the Center for Implementation. Blue tickets are for those of you attending the session, building meaningful partnerships for impact, and that's being led by Dr. Laura Middleton. So if you have a red ticket, and maybe we can get our volunteers to come in. If you have a red ticket, your session is in the conference center, room 6205. For those of you with a blue ticket, think blue, Bentley Center, breakfast, where you met this morning, that's for blue tickets. So your session, if you have a blue ticket, a blue morning ticket is in the Bentley Center. Again, we have coffee and pastries available in each room in the morning. So the idea is you go to your room first, you get your coffee and your pastries in your room, meet your new friends, start your discussion. So you see lots of our wonderful volunteers have on the UNBC shirts. And so we have Santiago, wave, and we have Meow, 2 of our wonderful Masters of Science in Nursing students. If you have questions or get lost during the day, ask anyone in the UNBC shirts. We'll be able to help you. We have Matt back there, although he put a jacket over his stylish t-shirt. But there's a group of people here to help you. So let's get moving. So if you have a red ticket for your morning, so that's the session, selecting effective strategy to address barriers and facilitators to change, you're gonna follow Santiago up to the conference center. If you have a blue ticket, you're gonna follow Meow and you're gonna go back to the Bentley Center. That is the conference center. What? Oh, that's okay. Just show up and tell them you lost it. Follow to the right room. Blue Bentley Center, red conference center. Hey, you?
Going.
Good.
Great day.
Yeah.
Yeah. Yeah. Well. This day, we had talked about the fall, of the importance you had on the thematic analysis reforms or something. The one on this morning, you suggested to go to the right. I just wanted to see what you were doing.
So I wanted to go to
Okay. I just wanted to check in with the.
yeah, originally I wanted you to go to and you're wrong, or either wrong. Or that prior. She's coming back to see it. Get her back. And I asked the ideas and articles for the take the course. I'm actually taking one on the integrated care foundation from the international foundation integrated care, and it's all in history of all.
Okay, I'd be happy to have have a look at it.
But if
How's
you find the wrong one, that's my suggestion.
How's the timeline looking for the list, man? And stuff.
I will respond tomorrow. I'm almost in your paper. You'll get it back tomorrow.
Okay, I figured you got a lot going on this week, so I wasn't.
Well, you know, but you would have got the conversation back on Monday and everything had been not.
With the shifting, it's a slight scramble. No, yeah.
It'll still be a great day.
It's, we've got like all the partners in the room, like that's step one, and if you've got the right ingredients, like you ship the bacon, so.
That's right.
Okay, great, thanks.
Do you know where you're going? To your room?
Hi, Sarah. But, yeah, a little bit more. I mean, is it that or is it just? Well, from my perspective, it's about being tired. I mean, we can.
Scale up. We use the word scale up, okay?
Of course. There are things that are. Keep saying that, you keep saying, well, what can we be doing together, right? Exactly.
Glad I told you. I spoke tomorrow. Paul and I co-supervise Greg in his PhD.
Yeah. I really think that you had to say.
Well, the other thing I'm helping with and so like, I want to really
including the money.
Yeah, I know.
It's wrong, it's perverse, it perverts everything.
Not paying for. Thanks very much.
Yeah.
Okay.
That shouldn't be a fact.
I mean, this is the awful thing.
So.
Could you send me that?
To comment on it. And
yeah. So what was our?
and they did their job. And someone good interesting, right?
Let's just think.
And I now have.
Yes.
Well, this is there's too much.
And just to say.
So,
Working on.
when in here, you're gonna be here at lunch yet?
What happened?
Are you,
to
which lunch are you going
Like I
to?
said, that's fine.
The service network or the language lunch?
So if you could.
Maybe
Certain
the service
things-
network lunch.
the hospitals
That would
were in
be-
this.
I will get
Very
Rich to
helpful.
talk to you,
By
he's the
the,
director of the service.
purchase
Get up with
assistance.
training and
They want to
all.
do things that pay
And
the
we,
money.
there's really lots of opportunity for collaboration. We do lots of.
They ignore it, and so, I mean, it's actually one of
So-
the many reasons I got frustrated with that. I mean,
Rich was just here, but I don't know what you went to, but I will find him and you.
I had,
Okay.
middleman.
So yeah, do you know where you're
I
going?
don't want you to see
You want
those
the red
pictures, you
ones?
want to see these. Because they're the ones that make me.
Yeah.
So it kind of, bothers- I mean, perversely, it's the same thing as demolition. It has, yeah, it does, yeah.
Our double Andy is here sometimes. That's. Which people.
I'm gonna say I agree with them.
Well, you know what, there's so I'll tell you, Netherlands has squared the curve in dementia care. So they put you in, like they have long-term care, all long-term care is dementia care. Meow, would you help Manjeet get to his room?
No.
This man here? Would you help him? So they keep you alive and active and moving, and then you die in 7 days to 2 weeks at the end, and you're in long-term care. Severe deployment, they can keep you active, moving, engaged, meaningful life. It's, and I was there. You know how they do it? It's all different ways. So we all hear about Hogovic, not the greatest model. There's Temple Louise, which is very much a tech-enabled facility. They're able to do it. They have more urban people, more educated class that really kind of gravitate to that choice. But my favorite, and I can't wait to give Aaron my PowerPoint presentation, 95 pictures that I took there, is the dementia farm.
Oh.
Legit, it's a farm. It is, and they have day programs. Everybody goes to
Do you have
day.
any other readings?
And their people sleep at night. They have a whole different model of care.
Yeah.
And it is the best I have ever seen, and I've seen a lot. And this, if we can take pieces of it, we can make the biggest impact on elder care in the north. I cannot tell you how excited I was to see that. We traveled all over the Netherlands. We moved all over the Netherlands to see all of their excellence and innovation for long-term care. All different models, because there, long-term care is only dementia care. Their philosophy is, if you don't have dementia, you can stay at home. And their home care is so strong that as long as you are capable of making decisions, you stay in community. There is no long-term care option for
That's
you.
brilliant. I love that kind of a mantra.
But this is
Yes.
what it's all about, we need to thinking.
They also have,
Okay.
listen to this, they have no locked doors. Even if you have dementia, there's no locked doors. So Temple Louise, this is what we need in the north. They all have a watch that they wear. It looks like a watch. I saw residents with one, but that watch is tagged to the resident. So when they walk down the hallway, their door just naturally opens. The watch will open, will trigger, so they don't have this, you're going into other people's rooms. Your watch will trigger open. If you going to the elevator, the door will just naturally open. And based on your watch, will take you to the floor. So it doesn't matter what button you push, you will get off at your
So
floor.
anyone who's.
And because your watch triggers it, so you don't end up, because, and it allows them to be free. And then, when people, people are allowed to wander around the community. And when they get lost, they have trackers on them. So they can run the tracker, find where the person last day, and then drive the bike up to go get her. Now, at the same time, they push an alert to within a 1 kilometer radius of where that person was. And they have all the community people, so all their high school students, all their store owners, they've done all of this work in the community. All are downloading the app, and it pushes out the person's photo and where they were last seen. And it's like, where's Waldo? All the high school kids, everybody is out to go find the person and and they only have that as a backup before they get there on their bike. So maybe dinner time, they just, okay, thanks so much. And I said, oh, I said, are you using this every day? Like, how often are you triggering this? I'm like, about 4 times a year. We'll trigger that alert.
No.
And she said it's great because it's the community are much more dementia friendly. And it only pings the cell phone with the app in the radius of where the person was. So if you're in Canada, you're not going to be at all, even though you live there, your phone will be pinged. So it's a great use of technology.
Yeah, we have a thing like that for our cat. So if we can do it.
But you don't think about this, but they have a notebook about our cat. So I like so many great ideas.
That is so, yeah, we've been there for a while.
Oh, yeah. So, do you guys know where you're going? Yes.
Well,
Yeah.
good.
Would you like to stay and go back to the workshops? Or take plans for Would you like a tour? I give one of our students. Absolutely. Let's walk back to Bentley Center and I'll pull somebody and we'll get you a bit of a tour. Would you like to lead our lab? Mark, I'll see you later.
It's a lofty ambition, isn't it? But anyway, you've got to.
So us academics all have many hats. One of them is I run the Center for Technology Adoption for Aging in the North. So we aim to be the bridge between industry and all of these technologies that are being developed and be the bridge to connect them to older adults, their care partners and our health.
And what's this one about growing your own food?
Yeah, so again, the health system will, I'm the only person who does aging research. So anytime they've got an issue, they call me, a rec therapist called me up and said, hey, we got this really isolated person who won't come out of a room and hates everything. Can you come help? And I said, yeah, I'll come talk to her. And, so I went,
No, I don't deal with it.
right? But I was loving to know her. So I went and started visiting her and having coffee and just listening to her story. She was a draft dodger. She, lived off grid and her kids had put her in long-term care because she was now quote unquote a risk because she, yeah. So, but she hated it. Life was miserable. And I said, well, what would make life a bit better?
Oh, yeah, I think that's a question of that one. Yeah.
Oh. How the question is I gotta lurk around here. Yeah. That's just part. I don't want to see that. Well, we're trying to get assignment for this class, but like, do I really? No. Yeah. That's what I want.
No, that I feel.